So I go to the point right away, to the point, what is the most important. Okay. So hypercalcemia means your calcium high in the blood, but not in the bone, and that's why your bone is not strong. Osteoporosis. And what is the medication that I use? Calcitonin. So know this name also. Calcitonin, actually, this is one of the hormone from, where is this come from? From?
Yeah.
Okay, your thyroid gland have T3, T4, and calcitonin. So this calcitonin is the one that regulate your calcium. This hormone come from thyroid gland, it regulates your calcium. And when we give this patient calcitonin, this calcitonin will kick the calcium go back to the bone. That's exactly the test question that will ask you, how calcitonin work? Why when somebody hypercalcemia, you give them calcitonin? Because the way calcitonin working is, hey, get out from the blood, you have to go back to the bone. What is your calcium level? Blood level. What is your calcium level? Blood value.
9.5.
You have to memorize this. If you see different book, a little bit different, that's okay. Okay, but be careful, a little bit tricky here. 4.5 to 5 milli equivalent per dl. Pay attention to this one. They don't do this to other electrolyte, but they always do this to calcium. They use two different units. So if I say milligram per dl, it's 8.6 to 10, around that number. But if I trick you, and I feel like they trick you, if they change the unit to milli equivalent per dl, then your answer is 4.5 to 5. It's half. So I saw one tricky question. For them, it's not tricky, but for you, maybe some of you, maybe you feel why they trick us, right? So I see the one test question said, you have a patient with 6.2 example, right? Right? Let's say 6.2, but then they put milli equivalent per dl. What do you think? Is this patient hypocalcemia or hypercalcemia? Hyper.
Hyper.
So do you see how important is this? If you don't know, you don't read milli equivalent per dl, and then you only memorize 8.6 to 10, if you only memorize those, you will think this is hypo because it's under 8.6. And then your answer will be wrong because it's your answer will answer about hypocalcemia when actually this patient already hypercalcemia, right? And usually the question that I see is they will ask you, hey, if somebody 6.2 like this and they need stool softener, are you going to give them thumb? Are you going to give them thumb? Why it's difficult to write something here. What is thumb?
It's calcium, man. Calcium carbonate or something, right?
Yeah. All right. So am I going to give them thumb? Of course not, because their calcium already high actually. Right? And since I'm talking about here, let me add here. I want you to remember this. Ooh, what did I do? Okay. Calcium. Where is your calcium? Where can I find your calcium? Isn't that
your bones, your teeth?
Yeah. So let me remind you, your calcium always opposite from phosphate, correct? What is your normal lab value for phosphate?
3 to 4.5.
Yeah, make sure you already memorize your lab value, okay? And again, if it's a little bit different than it should be, it's okay because every lab, they have different way to do the test. Alright, so this is calcium, this is phosphate. Remember, calcium and phosphate always the opposite. Calcium and phosphate always the opposite. And yes, your calcium and phosphate, they are inside your bone and in your teeth. That's where your calcium, okay? Calcium and phosphate.
Miss Ina, what you be meaning when you say bone and stone?
That's hypercalcemia. Just wait, okay? I'm not yet say that, right? If you see the word hypercalcemia, that means the calcium, let's say more than 10, right? Milligram per DL. So to make your life easy, yes, I always remember this. Every time you see the word hypercalcemia, remember bone and stone means they have osteoporosis and they can have stone everywhere. Okay? Bone and stone to make you easily memorize. Every time you see the word hyper, not hypo. Every time you see the word hypercalcemia, remember bone and stone, they have osteoporosis and they have stone everywhere. They can be in the gallbladder, in their kidney, that can happen. And then every time when you see the word hypocalcemia, always remember what? That means this one can be less than 8.6 if I use mg per dl. What should you remember if I say hypocalcemia? Since you remember bone and stone, maybe you remember the opposite.
Low bone density.
Oh, yeah.
Every time you see the word hypocalcemia, always remember Chifostek, Truso,
And tinnitus.
and tetany. Tetany, right? From the word tetanus. Tetanus, tetany, they are related. So Chifostek is the one that I tap your cheek. I do the test, I tap the cheek, right? And then they will twitching, they will jerk. So when you have twitching, maybe you have hypocalcemia. When you have leg cramp, maybe because hypocalcemia, right? And then the one that Truso is the one that I check your BP, why your hands shrink. So this is very common test question too, right? Why everybody call me during lecture? Don't do that. Okay, so check the BP and then the hands shrink. So that's usually because of the that's what we call Truso test. Truso.
Is this the Shiva,
Yeah.
yeah, those two tests, right? Okay.
Chifostek, Truso, and tetany means spasm, the muscle jerking, right? Or seizures. So something with the muscle when they hypocalcemia. This one guarantee you have to memorize. You have to know this really, really well. Guarantee. Make sure you memorize that. Okay? And then all that lab value, you have to know your lab value. No, this is already term 3, already going to term 4. You have to memorize all your lab value.
The lab values, do we just go based off of what we have on ATI? Because these are different.
It will not different too much. So wherever you open the book, it will be a little bit different. So sodium, 135, 145. Your chloride. Tell me if you know the answer. Answer me, right? And then your magnesium, your phosphate, your potassium. Put them together because easy to remember. Magnesium here is 2.5. Okay. 1.5 to 2.5. And then your phosphate here is 2.5 to 4.5. And then your potassium here is 3.5 to 5. So easy to remember. That's why I always put this in line, because my magnesium is 1.5, my phosphate is 2.5, my potassium is 3.5. So put them together to make your life easy to memorize thing, right? Your albumin is the same with your potassium, so that's also 3.5 to 5. All right, so do yourself, make your list, but I will not spend too much time here because we want to talk about the osteoporosis. Any questions so far? A little bit different, it's okay, because when you work, they will send you the range. It will not far away. So if in NCLEX, if they want to make sure to give you patient with abnormality, they will make really abnormal. It will not at this border where really close. Okay. So with that said, let's watch this one, osteoporosis and medication.
Okay, so welcome everyone, and thank you for joining us today for Osteoporosis Canada's webinar on medications and osteoporosis. Top 5 things.
Not this one. Let me show you the one that omits right away. Just wait, sorry. The second one. This is the one.
A variety what the calcium and vitamin D supplementation or exercise will do for the person. These medications have been shown to prevent fractures in clinical trials, which is the main purpose for treating osteoporosis, trying to prevent future fractures. They also raise bone density in a significant way and typically are well tolerated by the different types of medications that we have. The most popular category of medication these days is the bisphosphonate category. This includes a variety of tablets as well as several forms that are given intravenously. These are all effective medications. They prevent the fractures. They most commonly do not cause side effects for most of the patients, and they do definitely prevent fractures in a significant way. Perhaps as many as 50 to 60% of fractures that would have occurred without treatment will be prevented. Another category that is still oftentimes discussed is hormone therapy, because for women of the right age, this sometimes offers benefit for hot flash suppression and perhaps lowering of cholesterol and other benefit. But this must be weighed against the risk of breast cancer, blood clots, heart attack, and stroke that are associated with using postmenopausal hormone therapy. And so for many women, hormone therapy is not a good choice. In some cases, it might be used in women in their 50s based on the current data.
Okay, hold your thought
Burley,
if you have
bringing you
questions. Let me show you one more before you action.
A look at the drugs used in the management of osteoporosis. Osteoporosis is a condition that is characterized by a compromised bone strength that then predisposes a person to an increased risk of fractures. This is seen mostly in old age or postmenopausal women. So in order to understand the drugs, we'll take a quick look at what happens in osteoporosis and how the drugs affect this process. Our two main players are the osteoclasts, which are responsible for bone resorption, meaning breaking down bones and releasing minerals, and osteoblasts, that are responsible for bone formation. Physiologically, bone is constantly in a state of remodeling, so it's being broken down and reformed continuously. This happens because it maintains bone strength by replacing old bone with new proteinaceous material that then ossifies over time. And of course, there is an element of iron homeostasis. In osteoporosis, the balance is significantly in the favor of the osteoclasts, so in favor of breakdown of bone, leading to a decreased bone strength. You can have primary osteoporosis, which happens post-menopause as estrogen levels decrease and osteoclast activity increases because estrogen acts to inhibit osteoclasts. Or you can have primary osteoporosis as a result of old age, where you have less vitamin D activity, meaning less calcium being absorbed from the gut, and so the body starts taking calcium from the bones instead.
So that's the important information, okay? That's the important information why we can have osteoporosis. Because especially ladies, post-menopause. So after menopause, our estrogen low. So that low estrogen, that's not good, right? So here it says it inhibit the osteoclast. And by the way, make sure you know the terminology, you know your ANP, right? Osteoclast, it break the bone. Osteoblast, I make the bone. Okay? Osteoclast, I break the bone. Osteoblast, I make it, blast. And also when we old, maybe we don't have enough vitamin D, and because we don't have enough vitamin D, then we don't have enough calcium. Okay? And then this, because we don't have enough calcium, that's why the calcium, they take it from the bones, so the calcium leave the bones, and that's why the bone become fragile, easily fracture. Okay? So this too is very, very important information. Please write it down somewhere in your notes. Okay? Important.
Secondary osteoporosis happens as a result of some other pathology, such as rheumatoid arthritis, endocrine causes like hyperparathyroidism, Cushing's, or diabetes. Malignancies and glucocorticosteroid use are also other causes.
Okay, and also this one is very important. Other cause of osteoporosis, maybe they have Cushing. Remember Cushing, their extremity is very skinny, right? So don't let them fall, because if they fall, they easily fracture. Correct? Maybe they have cancer. Maybe they use steroid too long and then they now look like Cushing. So this is secondary, means they have osteoporosis because of something else. And why hyperparathyroid? You have to put everything together, okay? Combine all your knowledge. So don't put in your brain block, oh, this is only methods, or this is only pharm. No, now put it all combined together. So you already learned that parathyroid, right, endocrine system. If you hyperparathyroid, that means you hypercalcemia, correct? One more time. If you hyperparathyroid, that means you hypercalcemia. Yes?
Yes.
Bone and stone. Yes? Osteoporosis and stone everywhere. Correct? So this is maths, what I say. So if they hyperparathyroid, they actually hypercalcemia. That's why they osteoporosis. Bone and stone, bone and stone. Okay? And rheumatoid arthritis, because this is autoimmune disease, but it affects their joint, right? Their joint. They also have osteoporosis. So these are important stuff that you need to know. Your ATI question will be about this, right? What causes osteoporosis, right? Menopause, be careful with elderly, especially the ladies, because of the estrogen low. Don't let them fall. Don't let them trip to your rack, and then they break their bone.
Alright, so let's get on with the actual drugs themselves. A lot of them focus on reducing osteoclast activity, but I'll include some that increase bone formation at the end. First off, we have the bisphosphonates. They're often the first line therapy. Examples include alendronate and zoledronate. The way these work is by attaching to hydroxyapatite, a mineral form of calcium in bone. Then the osteoclasts will bind onto the bisphosphonate and is therefore unable to bind to the bony surface. Bisphosphonates are then able to enter the osteoclast and disrupt the enzymatic processes within the osteoclast, preventing bone resorption. They also play a role in osteoclast apoptosis and in reducing development of precursor osteoclasts. Side effects of bisphosphonates include acid reflux, esophagitis, and ulcers. People experiencing these may be given the bisphosphonate IV. Other side effects include jaw osteonecrosis, which is an exam favourite, and hypocalcemia. Next, we have the selective estrogen receptor modulators, or SERMs, an example of which is raloxifene. We use these because estrogen is involved in osteoclast inhibition by inhibiting rank L, which is a protein that increases osteoclast activity. But estrogen also acts by inducing apoptosis in osteoclasts. Estrogen itself could in theory work, but it comes with an increased risk of breast and endometrial cancer. SERMs are estrogen receptor agonists in the bone and in the heart, but they are antagonists in the breast and the uterus. Denosumab is our next medication. Parathyroid hormone can stimulate osteoblasts to...
Okay, if possible, take a picture of this one, if possible, right? Take a picture of this. This is something that you have to know. So alendronate, soledronate, ending with dronate. Remember, every time you read this name, remember it's the osteoporosis medication. Memorize that. Okay, this is not understanding. This is memorized. Memorize the name. Okay, once you see the word alendronate, remember this is for osteoporosis, and the class is biphosphonate, phosphate, right? Phosphate. We talk about bone. We talk about calcium. We talk about phosphate. So the class is biphosphonate. It must be there is 2 phosphate inside, right? And then it tell you that how it works. It bind to this hydroxy apatite, right? Hydroxy. And then they will cause this osteoclast. By the way, this is again the cell that class means destroy the cell, right? So causing the osteoclast will bind this biphosphonate, and so it will not reach the bone. So I don't want this osteoclast go to the bone and destroy my bone. Basically, to say it in easy way like that, right? And then this biphosphonate will enter the osteoclast, will disrupt the enzyme process. So I don't like you, osteoclast. You continue break my bone. So I will stop you from working, osteoclast, right? So apoptosis means I kill them. Apoptosis means they self-destruction. So I want to increase the destruction of the osteoclast. I don't like osteoclast, right? And then look, and then I will reduce my osteoclast. So not so many problem with that. But look at this. The side effect is what? Esophagitis. That's why I told you when you eat this in the morning, sit down, stand up, don't lay down. Because this is your GI. If you take this medication, it will irritate your GI if you lay down. And they can reflux, and then they can cause ulcer, because when you reflux, when you regurgitation, that's your gastric juice that will go to your esophageal, right? So remember that. And then this one also, did he said this is a very common question in the past? Yes. So write it down somewhere, right? Jaw osteonecrosis. I will post this also later in the in your canvas, right? I will give you this so you can watch this video again. But remember this jaw osteonecrosis. So I don't know how, but the bone at your jaw, it destroyed. It necrotic, it died. And we don't know why, because of this medication. This is not understanding. That's why pharmacology is tough, because it's memorized. And then it's tough because every medication can have different problem. Even though they are the same class, but special for alendronate, careful with the jaw osteonecrosis. What does that mean? Means you always want to monitor their jaw. You don't want them telling you, I feel my jaw is sore. You better quickly report to doctor just in case this is actually the complication, the adverse effect of that alendronate. Okay? And also the side effect can be hypocalcemia. So now can be finally way too much. Now it become hypo, not hyper anymore. Tembok, what is your question?
These are the adverse effects, right? You said?
Yeah, side effect.
Okay.
Should be adverse effect, because side effect is something that normal, that I will tolerate, but adverse effect is something that I don't want it happen. But sometimes they use side effect and adverse effect like intertwined, right? But in this case, of course, I don't want jaw osteonecrosis, so it should be the adverse effect. Tembok, what is your question? I see you raise your hand.
For the alendronate, how long do they sit up for? Like 30 minutes, 40 minutes?
30 minutes.
30
minutes.
minutes? Okay,
Yeah.
thank you.
Yeah. Any other question? So you will see that a lot, okay, in FDI question. And then you have, yes.
Are you able to give us permission to record here or not?
I asked and they don't allow that.
Oh, okay.
Yeah.
Who is
They don't allow
that asking that? You can do Windows G. I just learned.
Windows G? Okay. Okay, I'll go look at
choose
it.
capture.
Windows G. Thank you very much.
You're welcome.
Yeah.
Appreciate it. Thank you.
Mhm.
All right. Continue. And then selective estrogen receptor. Okay. Selective estrogen receptor, raloxifene modulator. So SERM. So if you see this name and come back and see what is this, something with the estrogen, because we already said when a woman, when the estrogen low, that's when they easily break their bone, osteoporosis, because their estrogen way too low, right? So that's, if you break your bone because you low estrogen, then let me give you estrogen. But then this is the problem. If I give you estrogen, now you high risk for cancer, right? Because if I give you estrogen, it can increase your, for ladies, especially breast cancer, endometrial cancer. So it's really difficult. I want to help you with this, but then the adverse effect can be cancer with the breast, with the endometrial. Okay. But then this medication act as estrogen receptor agonist, means it work together in the bone. It's good in the bone and in the heart, but then it work the opposite. Antagonist means the opposite in the breast and the uterus. So that's make it difficult. It bless one area, but it occurs to the other side. I can say that. Any question? Who raised the hand? No? No question? And then let's go to the next. Let me continue. Okay.
In the breast and the uterus. Denosumab is our next medication. Parathyroid hormone can stimulate osteoblasts to produce RANKL, which increases osteoclast activity, but denosumab is a monoclonal antibody against the RANKL. It has been shown to be as effective as the bisphosphonates, and it is mostly used in postmenopausal osteoporosis. The last one to mention before we move on to the ways of increasing bone formation is calcitonin. This directly inhibits osteoclasts and is secreted by the parafollicular cells of the thyroid. It hasn't been shown to be as effective as bisphosphonates in osteoporosis, but can be used alongside bisphosphonates, especially in treating hypercalcemia. The main side effect is hypocalcemia. Okay, so now let's have a look at some options to increase bone formation. We mentioned parathyroid hormone earlier, but as well as leading to RANKL production and increased osteoclast activity, it does have some favourable effects in osteoporosis. It stimulates the maturation of osteoblasts, it increases calcium reabsorption at the level of the kidney, and increases the activity of 1-alpha hydroxylase, the enzyme responsible for activating vitamin D. In case you don't remember, vitamin D increases calcium absorption from the GI tract and calcium reabsorption from the kidney. As well as increasing osteoclast activity, it also increases osteoblast maturation. It also has a role in the negative feedback leading to decreased parathyroid hormone. Now,
okay, pay attention to this. Basically, this is the most important that you have to understand. I don't like osteoclasts. Osteoclasts, you break down my bone. I love osteoblasts. No, yeah, right? Because osteoblast is the one that make the cell, right? So you have something that destroy, you have something that to make the bone. So that's why all my medication, I try to increase absorption calcium, right? I try to make your osteoblasts working, but I hate your osteoclasts, right? So play with those words. So I don't like you continue to break my bone, but I like you to build my bone. Okay, rational, 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 rational. And let me mention about this because we're talking about vitamin D. We need sunlight, right? So this is Zoom time, but we need to go outside, maybe walk the dog or go to the beach, right, with your mask. Get some vitamin D, right? Get some vitamin D because we need that vitamin D at our skin. It can help us, right? It will activate, become calcitriol. So your vitamin D and your calcium, very close relation. Because when I activate your vitamin D, it become calcitriol. Our skin receive the light, make vitamin D, calcitriol. All right, so we need that. And I mentioned for people that kidney hemodialysis, they need calcium. They hyper with everything. They hyperkalemia, hyperphosphatemia, but they hypocalcemia. So people that dialysis, renal failure, they need calcium. They need calcium. Okay. So many of us, we need calcium and we need vitamin D. So if you see this one, right, you will see that's bottom line. That's the case. I want to increase your calcium absorption from the gut. So I make you take more calcium from your intestine, right? I make you take more calcium from kidney. Don't throw it away. And then I will increase your osteoclast activity, right? And then I increase your osteoblast maturation. And then I will use the PTH negative feedback. Bottom line, everything that increase my calcium, that's what I want. Okay? And what we say here is I want your calcium in your bone, not calcium in your blood. I want your calcium in your bone. Right? So that's the function of the parathyroid. I want to increase osteoblasts, right? I will stimulate your blasts. I want to increase your calcium reabsorption. I want to increase activity of this hydroxy activity, activate vitamin D. Everything that make more calcium in your bone.
Remember that the overall effect of parathyroid hormone is bone resorption, which of course is not what we want. But feriparatide is a form of recombinant parathyroid hormone that, when given in low doses, actually has a net effect of bone formation. This is because it mostly stimulates osteoblast maturation without having much of an increase on bone resorption. Finally, we have vitamin D itself, which is very commonly given to help support patients at risk of osteoporosis. Now you may be thinking, why would you give vitamin D if it increases osteoclast activity? Well, similarly to parathyroid hormone, it does have effects on bone resorption and bone formation. But remember that vitamin D also really helps in maintaining appropriate calcium and phosphorus levels in those at risk of osteoporosis. So that is why it plays a big role in osteoporosis management. Finally, remember that activated vitamin D must be given to patients with renal failure because they can't activate it themselves.
And surprisingly, in America, many of you, even me, I have low vitamin D. So one time I go to doctor and check everything, all my lab, everything beautiful except vitamin D. And then I heard many students also have that problem. Why do you think in America we have many problems with vitamin D?
That's true, Messina. Like, it's really common. I've heard of vitamin D being really low in a lot of people. I don't know.
Not enough sun exposure.
Yeah. Yeah, that's true, right? Many students. So, yeah, maybe some of you too have that vitamin D. So don't take too much calcium, because too much calcium you can have bone and stone, right? Too much calcium. So everything should be balanced. Everything should be balanced. Too much is not good. If too low is not good too. I know, no time to go out and get sun exposure. Yeah, but we have to make time. So sometimes we really need to rest. We work. I don't know. Some people we work, forget to rest. Any questions so far? Also, don't forget, since this is related to calcium question, why we need to encourage somebody to walk, or at least if elderly in nursing home, if they cannot walk, then we have to turn them every 2 hours. Besides to prevent pressure ulcer, what is the relation with the bone? Is there any reason why we always want to make sure they walk or turn every 2 hours?
Pressure injuries for the bony areas.
What is demineralization means to you? What is demineralization?
They lose minerals.
Yeah, that's why if they continue in bed and they don't walk around, they don't move, isn't that they easily become osteoporosis easily? Because demineralization. So basically their calcium will go to the blood and leave the bone. Okay,
So it's the same as like saying immobility or like a mobility is called similar to that, right? Okay.
Yeah. So basically I want my calcium in my bone. So don't leave my bone. If you leave my bone too much and go to the blood, that's why you hypercalcemia, high in the blood but low in the bone. And that's when they have osteoporosis. Hormone and drug. Oh, maybe this is correct. It is, but the beginning it starts with the word hormone. Okay. I think it's the same. So talking about the hormone, aldosterone, we know that one is from the adrenal cortex, and that's steroid. Be careful if I give you too much steroid. Now you can have easily fracture. Basically, you look like Cushing, right? And androgen is the sex hormone, but it's also corticosteroid. It's also steroid. And then you have anti-thyroid drug. This is for thyroid. Thyroid is the one that iodine. So they do mix the hormone and this medication for osteoporosis in this chapter. That means it's the same with the PowerPoint that I posted last week. Okay, so double check the PowerPoint that I sent you. I already post in Blackboard how many weeks ago. That's when Isaac Lee asked me about that. And this is the biphosphate that we just discussed. Okay, so that's the calcium modifying drug, prevent bone from losing calcium, increase the bone density, move the blood calcium go to the bone from the blood, right? I move the calcium from the blood, go to the bone, and then I want to bind that calcium in the bone and prevent osteoclasts from destroying. So I don't like osteoclasts. I do like osteoblasts. If you're difficult to memorize that, write it down somewhere, a big one. I don't like osteoclasts. They destroy my bone. But I like osteoblasts, right? Blast, use B because they make my bone.
I usually use the like the class, like for clash or crash, and for blast, it's for blast or build. So they helps me out a little bit. Just throwing it out there.
Thank you for sharing. So other student, if you want to use that trick, use it. Okay. And then corticosteroids, similar like cortisol. That's your glucocorticoid, right? Also, that's from your adrenal cortex. Very important because that's your sugar. And then estrogen. Estrogen is the sex hormone. Not only ladies have estrogen, but the boys, you also have estrogen because you do have adrenal gland, right? So your drug for osteoporosis, it will activate estrogen receptor. Because many times they have osteoporosis because they low estrogen. So how I make your estrogen work more, better, or I give you estrogen. But again, be careful with that adverse effect. It can be cancer. Okay, basically I promote your calcium retention in your bone. So I want the calcium in the bone. Come on, whatever that make that calcium stay in the bone. And then I will block, I antagonize the estrogen receptor in the breast tissue and uterine tissue. But that's why it become dangerous to the breast and the uterine. They can have cancer in the breast, cancer in the uterine.
Miss Ina, will, like, if you have osteoporosis and let's say if you've had it for like years, you know, can it lead eventually to having cancer in your like bone marrow or anything?
It can, but not always. But for sure, you risk for fracture.
Okay.
The number one concern will be fracture, right? It's not really connected directly to cancer. It's yeah. The cancer can cause somebody the bone become fragile. Yeah. Okay. Yeah. Or also hormonal contraception, because some hormonal contraception, that's the one that estrogen, right? So I use the hormone. I want to suppress ovulation for intention to prevent pregnancy. That's hormonal contraception. And then this is hormone, and then hormone replacement. Because you don't have enough estrogen, then let me replace you with hormone, with estrogen. So you already know osteoporosis means they don't have enough calcium inside. It's not strong, bone density. What is the name of the test for osteoporosis? The name of the test? DEXA scan, right? I got this question in my English. Hey, is DEXA scan invasive or not?
No.
Okay, I mentioned that before. Let me mention again. It's not invasive. Something so simple can be your test question. They can ask you anything. They don't promise you what they want to ask. They only give you how many percent, guarantee 14% pharm. They will ask you leadership. They will ask you many things. Okay. And NCLEX is like it's like psychic. So once you answer wrong, they know your weakness. And once they know your weakness, they will continue ask you those questions that you're weak. And then you have a thyroid hormone agonist. Again, agonist means they work together, right? Antagonist is the opposite, but agonist means they work similar like your thyroid hormone. So it's mimicking your thyroid hormone. That's your levothyroxine, right? Your levothyroxine. T3, T4, so helping to regulate your metabolism. That's thyroid hormone agonist. So hormone, we know, we already learned endocrine system in med search, right? That's the chemical that go to the whole body from gland, target tissue, and then unlike some glands, such as from the salivary glands, secretion move through a duct directly to its site, but hormone will just go everywhere, spread. Our blood vessel, all the blood inside the blood vessel, but hormone is everywhere. They don't inside the tube or something, right? So there is no ductless gland. Okay, and then this is hormone replacement therapy, adrenal gland, sex hormone, contraception, diabetic medication, right? And people that usually do not have enough hormone, especially people that menopause, usually we give them this because maybe they complain to you, oh, why everything dry at the vagina? Okay, you need KY gel, KY gel. And then maybe they need hormone. Okay, let me give you hormone replacement therapy. But if you don't really need hormone, don't play with it because it's too many adverse effects. And number one, that usually problem, careful with blood clot. Okay, when somebody use birth control, when they use hormone, usually the problem is careful, they can get weight gain, right? Increase the weight gain. They usually can have pimples, right? But of course, the one that dangerous is careful with the deep vein thrombosis, so they can have blood clot. Okay, write it down somewhere. Remember that if you see that question. Okay, problem with birth control. Usually, I will have to be careful with blood clot. And then this hormone replacement therapy usually only short time, only to relieve menopause symptom. What is menopause symptom? Besides dry? What else? What else? Hot flashes?
Hot flashes.
What is your medication for hot flashes? What herbal for hot flashes?
Black cohosh.
Okay, remember that name, black cohosh, right? And then they maybe have night sweat also. Usually they have palpitation. So usually when menopause, they have problem with vascular, something wrong with their blood vessel. So that's why at night they cannot sleep, difficult to sleep at night, problem with the blood vessel. And then we replace their hormone. If they don't enough hormone, then we give them hormone. Any question?
Miss Anna, in black cohosh is over the counter, right? Herbal.
Yeah, herbal. So you always want to ask them, do you use any herbal that I need to know? Because doctor need to know just in case it interact with the medication that doctor will give. But that one they always ask you in the test also, black cohosh, okay? For hot flashes. 10:23. Do you need really quick 5-minute break? Do you need that or continue until 11?
Until 11. If it's 11:50, we'll be back at 11:30.
Break.
Yeah, I'll take a break.
Break.
Only 5 minutes.